All right, good morning, everybody. Good morning, everybody. I'm going to share the screen here and we're going to begin today's lecture. Let's see. Can everyone see this PowerPoint screen? Okay, great. So today, forgive the plain background. The remaining slides, the multitude of colors got lost and it was deceiving to the eye. So kept it simple so the colors didn't affect us all. But today what we're going to talk about is the Glasgow Coma Scale, and we're going to touch on a system called the Revised Trauma Score, which incorporates the Glasgow Coma Scale, GCS, and two additional parameters, which are blood pressure and respiratory rate. So we're going to talk about what these are, why we use them, why they're not just numbers, and why it's important that we know these, and that, at 2:30 in the morning that we can calculate these quickly, because they make a difference in what we do and where these patients go. So we'll start by an overview. Now, keep in mind with all of this, this is all EMT level stuff. We learned this in EMT school, and it's one of those things that sometimes you on scene you may see that there's a little bit of confusion in it. So we're going to have a brief overview, and we'll have a little homework assignment following this to ensure that we understand these concepts. So the Glasgow Coma Scale, GCS, this is a system that rates neurological deficits following trauma, a traumatic event, and there's three parameters that are used to measure the score. The score can range from 3 to 15. So you have your eye-opening response, your verbal response, and your motor response. These numbers add up to form your 3 or 15. Now, I'd like to say the number, whether it's 10, 12, 4, 9, whatever the case, that is essentially meaningless. You can tell just by that number that, if it's a 14, it could be a minor brain injury. If it's a 6, it's a severe brain injury. But what I mean by meaningless is there's a better way to verbalize the number, and that would be by breaking it down. And I'll give you an example. Let's say there's a GCS of 10. Okay, well, if there's a GCS of 10, does that mean that the eyes are open to verbal, that they had inappropriate responses, and they withdraw from pain? Or does it mean their eyes didn't open, they were oriented, and they withdrew from pain? Or their eyes were open, they were confused, and they had decerebrate posture? You see, it could go many ways by just using the number. But if you were to say something such as patient has a GCS of 10, and you say eyes 3, verbal 3, motor 4, then you could pretty much in your head figure out you could see what that patient's doing. So that's a lot more descriptive, it's a lot more accurate, and it's a lot more beneficial to coloring the patient. And that's one of the things that could help us very much on scene. So with that being said, these numbers, they're in order. We look at them, we might be confused, we can't remember. We might have a little chart, 2:30 in the morning, we forget. So we're going to go through how to memorize this a little bit better. We'll use a couple of examples, and I hope this sticks with you. So we'll go through the eye-opening response. Now, if you look at these, are the eyes open spontaneously? Are they open to verbal? Are they open to pain? Or are they not opening? If you remember the AVPU, alert, verbal, pain, unresponsive scale, that can kind of help you here. So, if you get on scene and the eyes are open right there, I know there are 4 in the eye category. I move on to the next one. The eyes open into verbal. That would be something, excuse me, sir, how are you doing? Can you open your eyes for me? And if they do, that's a 3. If they don't, give them a little painful stimuli, a sternum rub, perhaps a pinch of sorts, and see if their eyes open to that. If it does, it's a 2. If it doesn't, it's 1. So that's pretty easy to move through with the eye-opening response, and that's something that should take just a couple of seconds to do. Next, we move down into the verbal response, and this is your, you walk on scene, excuse me, sir, can you open your eyes for me? Yes, I can open my eyes. Okay, well, I know you're oriented, so you can knock two birds out with one stone there. Or you ask them these questions, whatever the case, and you're conversing with the patient as we do. Are they answering the questions appropriately? Yes, that's a 5. Okay, are they able to answer the questions, but they're confused? Are they able to answer some questions, confused in other questions? That can indicate a brain injury. For example, a call we had previously, this 21-year-old female was swinging on a rope swing, hit a tree. And, you talked to her, everything seemed good, but when you started asking math questions in particular, she couldn't do simple math, 5 plus 2, things like that. So, talking to her, she seemed like she could be okay, but, a 5 plus 2, if you can't answer that, we're confused, can't answer correctly, things like that. So we know there's some brain injury going on. So as we move down, getting into more and more brain injury on this verbal response category, you have the inappropriate words. Inappropriate responses, words discernible. So that could be something like, if I say, how are you doing today, sir? And you get a, dog rainbow 18-wheeler. They're saying words, they're not making sense. It's like a word salad. That's going to be your 3. Okay, your incomprehensible sounds or speech, how are you doing, sir? You can't make out anything. And then you have your no response. So a tip for learning this category is if you look at these 5 different points, you can see that they go from good and it's less, 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 less. So they're good, they're confused, but they can answer questions. They have inappropriate words, inappropriate sounds, they can't even make words here, and then no response. So it just goes downhill in each one of these categories. So that's a little bit of help on that. The motor response, this one can be a little tricky, but I got a pretty easy tip that can help you memorize this. Now, one of the significances of this motor response is it's heavily weighted, and what it means by that is there's 6 points assigned to that. So what that says is that this has the potential to cause the most injury to the patient. So if they have a low score in this, it significantly affects their GCS, and that gives a worse patient outcome. So a motor response, some points knocked off in this category is, some point getting down in this range, down to the 2, 3 points, things like that, that can yield a worse patient outcome than if they just simply open their eyes to verbal, is what it's saying. So this is a particular important part to assess. So let's get into the motor responses. Obeys commands for movement. Sir, can you hand me your arm? And he does. That's a 6. Purposeful movement to painful stimuli. So if he doesn't move his arm, okay, now let's say I'm putting a blood pressure cuff on him, or what, doing some procedure, and he kind of localizes to the pain, goes to the pain, that's going to be a 5. If I'm starting an IV and he withdraws from the pain, pulls away from it, that's going to be a 4. Then you go down to the decorticate posturing, which is pulling your arms and your legs into your body. That's 3. Decerebrate posturing is going away from your body. That's a 2, and no motor response. So in order to prevent this motor response from getting confused, one of the tips I have is that they obey the command for movement, they're acting normal. So that's a 6. And then for points 5, 4, 3, and 2, it kind of forms a pattern. So 2 away, 2 away. So the moving to stimulus, withdrawn from stimuli, decorticate, decerebrate. So if you're on scene, you can just kind of memorize that pattern of the patient's going towards, away, and that can help unjumble this in your mind. And then of course no motor response is 1. So overall the scale is 3 to 15. It's always best if it's much more informative if you give the points, 3, 1, and 4, 4, 2, and 3, etc. Because just saying a number strictly indicates whether it's minor, moderate, or severe brain injury. If it's a 3, then the only option is 1, 1, and 1. If it's a 15, the only option is 4, 5, and 6. But it's a good habit to get into. So, those are some of the things. Now, while we're on this GCS thing, the patient's baseline is also important. Perhaps a dementia patient is confused, but are able to answer questions all the time. So if their eyes are open spontaneously, they're confused, and they obey commands, their baseline might be a 14. So if you get on scene and they're confused, is this a traumatic brain injury, or is the patient always that way? And you know, that's one of the things that you can ask the family. Does the patient typically, is this the patient's normal? You know, and they'll be very happy to tell you yes or no. So we've got the GCS. Now, at the end, I'm going to send you this chart. I'm going to send you the RTS, the revised trauma score chart, and we will talk about the homework after. We got a couple more little slides to go through. Are there any questions on the GCS system while we're here?
Yeah, I got one.
Yes, sir.
It's not really a question, but if you look down at the bottom, minor, moderate, and severe, if you want to apply that to our color code, would it be safe to say that the 13 to 15 is the green, yellow, and red would apply?
It could, however, you could, and here's the instance with the numbers versus breaking it down versus just the number offhand, is let's say it's 9, you know, or let's say 10. Moderate, and if we say that's a yellow, let's say it's a 4, you know, their eyes are open, they're confused but unable to answer questions, but they're decerebrate posturing, so they're posturing. So that's a pretty significant head injury there if they're posturing, you know. So it could go hand in hand, but not necessarily an exact a rule of thumb. I feel that it could be a good rule of thumb, but it's to just, I would say that a moderate brain injury could be a red as well, you know, in certain cases, depending on how the numbers align.
Sure.
But if you think, you know, if you think otherwise, if you think it could be a good a rough rule of thumb, that, you know, if it's a moderate brain injury, we know it's not going to be a green patient. You know, it can work that way, certainly very easy, you know. But going down, the yellow could be the red, but the yellow is not going to be the green kind of concept. If that, you know, just based on the way the numbers can mix and match kind of deal. Now, if it was a, you know, if you use that same 10 and it's eyes open to pain too, and then you have they're a little confused. Now you have a 6, and then they withdraw from pain. You know, that could be a yellow very easily in a lot of cases. It just depends on how the numbers go. All in all, I feel that it would correlate fairly well, but there's always those exceptions, you know, if they're posturing kind of deal. So. Okay, any other questions on the GCS?
Just a little statement. For some people might have some confusion on posturing, maybe not, but just a quick little way to remember the 2 different posturing is like decorticate, like if you decor, like towards the core. So just an easy way to kind of remember that. So if it's decorticate, it's towards the body, towards the core of the body.
Very good tip. Very good tip. All right, now we will move on to the revised trauma score, which this is a predictor of if the patient should go to a trauma center. It incorporates 2 additional measures. So building on the GCS, you have your numbers for the GCS. You also have your systolic blood pressure with corresponding numbers, and your respiratory rate with corresponding numbers. So while we're looking at this, just how this works is, let's say the GCS is the 10. We'll use the example of a 10. So they have and this, I'm sorry, the scale goes from let me see, this goes up to 12. So the scale's on a scale of 12, under 11. they say you should ship to a trauma center. So let's use this example. If it's a GCS of 10, you're gonna have 3 points. If you have the systolic blood pressure of 90, you're gonna have 4 points, so that's 7. And if your respiratory rate is 8, it's gonna be 2. So 7, 9. So you kind of bounce it up. You find the best score and attribute it to the revised trauma score. So this is just one of those things where you'd look at it, you remember it. It's a little bit extra. We talked about on scene. The reason this came up is because we had a call. It was a great call for triage, a great call for doing some of the things that we always that we're capable of doing. And we got color-coded green patients. The patients were green, 1 yellow. And it led to a little confusion because we didn't know too much more than that. There were some things we could have done more, and that's kind of the aim of this revised trauma score, if it is something we move to. And it was, when you're triaging patients, the GCS is important, but there's other parameters that can help influence or that can help determine the status of the patient, such as the systolic blood pressure and the respiratory rate. So this factors that in to these 2 parameters into the GCS and gives you a much more clear picture of the patient's severity. So with that being said, let's see, from 0 to 12. So if your GCS is 3, no blood pressure, no respirations, so it goes on that range. But it's a system that's been around for a while. It's not as common by any means, especially pre-hospital. It seems like the GCS is the go-to. But with that being said, this is built into the triage system somewhat, and we'll get into that here in the next slide. So it's hard to explain this chart other than just to call out some random numbers. I feel that we could best explain it by moving on to the next slide, and just keep in mind that systolic blood pressure and respiratory rate is part of this revised trauma score. So as we move on, this is Acadian's START triage protocol. It's very efficient, very effective, and very familiar to us. I believe we've had a Medical Monday on this, not too distant in the past. But when you're going through this, the revised trauma score, we could go through this as a refresher. You can see that the respiratory rate and a measure of blood pressure is here and here. Now the issue is we are searching for a better measurement of blood pressure because this isn't always reliable, and we'll get into that as we get on this. So as we touch base on this triage, we've done this. We're not going to go too in depth on this because we've had a lecture on this, a class on this already. I'll send this so we can refamiliarize ourselves with it, but we're going to talk about the parameters of determining a GCS or the revised trauma score within this slide. So your GCS is applicable within this START triage algorithm. Down here, follow simple commands. Remember that was under the motor response. So that's your GCS measurement. You have your blood pressure measurement essentially here with the radial pulse. It was said that if they have a radial pulse is present, it's an 80 or above. That school of thought has kind of gone out the window because there were less people. There was some studies that proved that you could have less than an 80 systolic blood pressure and still have a radial pulse. They're kind of moving away from that. And then the respiratory rate parameter is here within this START triage. So one of the things is, although it's not the revised trauma score particularly, this covers it. Now the issue is we didn't know we were covering it, while doing that. So it's certainly one of those things that this brings the fact that the revised trauma score and these other 2 parameters are very important to our assessment of the patient. So these predict, yellow or red. If you're getting into this, you're not a green anymore. So now one tip I would like to mention while we're here, and I'll send this so we can just refresh ourselves. I'll send it in an email after this. But one tip, when you're going down on this side, This is not how you do this. Remember, start triage, it's rapid, lives are dependent on it. You want to get it done in about 30 seconds per patient. So this is not how to do it. Okay. Are they 1 year old? No, they're 30. Respiratory rate, is it over 29 or is it less than 10? And then I'm counting, let's say I'm counting Ed's respirations, so I'm counting for 30 seconds. Okay, he's breathing 9 times. I'll multiply that by 2, that's 18. Okay. Is a radial pulse present? Let me check. So I grab Ed's arm and I'm feeling for 10 seconds. Do I have a pulse? Yes. Okay. Follow simple commands. Hey Ed, can I have your hand? Now we're over a minute, just so how to save time, how to get this rapid triage is you go up to the car window of an MVC. Hey sir, give me your hand. Okay, right there. Is he gonna give it to you or not? Now you know. Okay. And then when he gives you the hand, you check that pulse while you count those respirations for 10 seconds and multiply that by 6. So you're doing all that within a matter of a couple seconds right here. Are there respirations? So sir, give me your hand. Here you go. All right. Nope. I don't have a pulse and he's breathing, 18 times. Okay. So breathing at 18. Okay. That's good. Radial pulse. No. Okay. So he's red. Tag him red. Move to the next one. So you want to be very efficient in this section because you're already dealing with some severe patients. So with that being said, one of the big differences with this start triage algorithm is you control any major bleeding during the triage process, which incorporates some somewhat of a treatment such as the SALT triage system. So it's a very, very nice triage system. And all of these are well within the EMT scope of practice. So I'll send these out to you. Now that we touch base on the GCS and the revised trauma scale, which incorporates the GCS, why is this important? What does it matter? Why do these numbers matter? And the answer to that is this, because we'll look at this head trauma algorithm. The numbers that you're given, the GCS, determine what you're doing and where these patients are going. So if you're not adequately assessing the GCS, if you're not looking at those other parameters such as the blood pressure and respiratory rate that are incorporated within the revised trauma score, you're neglecting the patient and you could be, you're not doing your job. So, and that could lead to detrimental patient outcomes. So, I'll send this protocol. We don't want to get really caught down the weeds on this particular protocol, but one of the things we want to point out as it relates to the GCS is you can see there's a branch in this algorithm based on a GCS level, and you use your clinical experience to tell you which way to go, your assessment to tell you which way to go. So you can see right here that GCS is important. Also, down here, you have some GCS ratings. Right here, if it's less than 14 in any of the following, they may need evaluation by a neurosurgeon if possible. So that could change the transport destination. So these numbers have influence and effect on patient care. Am I sending the GCS of 13 with a depressed skull fracture to Singing River Hospital, or is it better to go a couple minutes to Memorial? As of last night, I was, touched base with the nurse. She said it was Memorial has neurosurgery. The Singing River facility she works at doesn't. The hospital, that's an so it can help you to figure out where this patient should best go, whether we should fly them or not, etc. So these numbers are important. There's also, when you can use a CPAP. There's plenty of algorithms in there. We don't want to get caught in the weeds on the particular algorithms. We could spend all day talking about which one's which, and it could lead to confusion. But the point of showing this algorithm is that the GCS is influential on your patient care and on your patient destination. So with that being said, does anyone have any questions, comments, experiences?
I'm gonna add to it a little bit. So the
Okay.
GCS started in 1974. So this year it's 50 years old. If you go to a level 1 trauma center, they don't want to know an overall score. They want to know the numbers immediately. So if you tell them a 10, they're gonna look at you and tell you they want the numbers, how you got them, and what came to that conclusion. That's from experience going into level 1 trauma centers. The GCS was started for neurosurgeons to know what they were looking at, because CTs were still being developed at that time also, so that they were trying to figure out if it was a bleed or if it was an actual ischemic stroke causing that head injury. With all of that, any type of head injury, the patient needs to be elevated, the head needs to be elevated at least 30 degrees to keep the ICP from increasing on that patient also. And that'll help their GCS score sometimes. Along with the algorithm here, the GCS looking at the 9, it's a rule of thumb in just about any trauma or medical emergency that doctors use. If it's less than 8, they intubate, and that's to protect the airway. So that's one of the reasons that 9's in there. So it tells you if you're at that verge of where you're going to have to intubate that patient or not. So a lot of it goes into looking at the overall patient, like you said, and making sure you're getting a good score. Because a lot of times y'all hear it, the helicopter will ask if they're going to need RSI that patient when they get on the ground or not. So if we know that GCS is less than 8, go ahead and tell them yeah. And that's why they're asking for weight a lot of times, so they can go ahead and start getting those meds ready to RSI that patient if their GCS is less than 8. So just keep that in the back of your mind, that there's a lot going on when people ask that GCS score, not just wanting to know what actually is going on with them overall, but what they're going to need to do when they get to that patient.
Let me ask you this question, and this goes for everybody. There's no danger. How do I say this? That's probably not the right way of saying it. I think keep in mind that you can declare a patient of being a 14 while we're responding. You arrive on the scene, you do a quick assessment, you say 14. There's nothing that's going to keep this patient from not becoming an 8 within a minute, or a 15 when everybody gets there and you have a chance to really look at this patient, right? So the scoring system is a moving, is it fair to say it's a moving target and can change with when you touch the patient? That could change everything. Is that not a fair thing to say?
Very fair to say. It's especially on the downhill trend of it. It is one of those things where you want to constantly check it to see which way the patient's going. You don't want to. That's a very good point you brought up. If they're a 13 now, are they a 10? In 5 minutes, and if so, that's a very bad sign. That's an ominous sign, and that's a sign that hey, we need to start. This is a serious patient here. We need to do the best of our ability. Transport destination, things such as that. Yes, it's a fluid measurement.
What I'm looking for, I think, is the first unit to get there, be one of our basic units or be one of our ALS units, is to give information to follow up of when we're coming, so the battalion chief can be making decisions. This is a tool to help the battalion chief make decisions. The LZ, the response of the helicopter, let's say a basic or a advanced level arrives and he starts giving this kind of information, that's going to the paramedics data bank, and he's preparing himself as he gets there.
That's working on setting a trend for that patient, especially trauma patients that are every 5 minutes. You want to start trending them. So if you catch that GCS early and it starts trending down, and something's going on, if it starts trending up, then maybe they would have had a slight concussion, and the brain starting to get a little better from being bumped around from that coup counter coup.
I think one thing to keep in mind for me to try to remind everybody and myself also is this is, once again, not in stone, but it's one of these things. Each one of us is going to interpret it a little different. I can't tell you how many discussions, I think Chief Burnett and of course Moose, I think you've heard the discussion. We've all had the discussion about how valid the color code system is, red, yellow, red, green. You know, it's almost a subjective thing to each one of us, how we look at the patient and what we interpret it as. And then sometimes that gets lost in translation, but we've always been trying to paint a picture. The GCS of 15 is the same thing. With that, we have a little more way of painting the picture and getting it out there with a little more substantial guidelines, I guess. I like the fact that when we're saying moderate and severe, puts a number to it. Is that what that system is supposed to be trying to do, right? Or not? Why do we have that specific? Why did they? I know that you said the trauma surgeons, it was built on that. Is it something to give a picture of somebody, or is it something? Is it a benchmark at that particular time? What is it? Does that make sense?
So the RTS is to start trending that patient, because their numbers can change a lot quicker than the GCS numbers. So that's where the RTS comes into play, is they start trending that patient a little better. Are their respirations getting better? Is their blood pressure getting worse? Because a lot of times, once that patient hits an 8 or lower, they're going to go to a 3 because they've been RSI'd and intubated. But if they're watching that RTS, they know that that's a 0 because of the 3 for the GCS. But what does their blood pressure and heart rate do in the respirations? So that's where the RTS comes into play on the trauma surgeon side, when they're trending, putting them into surgery or bringing them out of surgery. Did they stop the bleeding? Or did they do what they were intending to do and start getting that patient moved towards a better outcome? So that's where the RTS comes in with all the surgeons.
Well, I'm going to make this statement, and I'm going to make it with tongue-in-cheek kind of sort of thing. Is I'm not going to change anything. I'm not going to suggest we change anything. I'm not going to ask that we change anything. But I would like to say, maybe we come to a consensus of everybody feels what is more important. Is the color code system more important? Is maybe the GCS system more important? Is there something better than what we're doing? One of the things that I want to guard against and want to make sure that we don't do is that we don't become lazy medics out here. You know, I think I hate to say it, but there's lazy medics. Every department has them. Every agency has them. They're lazy medics. And if we allow ourselves to be lazy, then when it comes down to crunch time and we haven't trained like we fight, or fight like we train, whatever the saying is, if we haven't trained and utilized that and then utilize it in the heat of the moment, then we're going to be lazy medics, right? We can, and I think this is a way looking at this and trying to make a determination of maybe not necessarily even going one or the other, using the combination, but knowing it and utilizing it in the field and reviewing it is important. Yes or no?
Yes, very important. And one of the benefits of the color coding system that we use that makes it so practical is, whereas the GCS will point out a neurological deficit, the color coding, it only essentially applies to that neurological deficit. So let's say if there is an amputation, let's say there's a lower leg amputation, GCS could be 15, but we got a severe emergency, and that's where that color coding system is, would be wonderful. It's without moving to a RTS or whatnot, the revised trauma score, assuming the bleeding, all that, but it would be a lot. The green, yellow, red is very effective for a full body. It can incorporate everything into your assessment. The GCS is built into it, in the cases in which it's necessary. Yeah, it's how I feel, and that's kind of what I feel you hinted to when you said a combination of the both.
The only thing that and I agree with you 100%. The only thing, and in our field discussion the other day, the review of the case we did, I mentioned about the blood pressure. One of the things I feel like is that we may not pay enough attention, and somebody correct me if I'm off base here. That's probably one of our most important bits of information, the blood pressure. Yes or no? All right, let me say why I say that, Chief. I see you squirming. Everything that I ever have read, seen, studied, and looked at, when it came down to it, and Moose helped me here from a critical patient care standpoint, is if you have a blood pressure below a certain point and you're not perfusing the patient, I don't care what else you do, that patient is not going to have a good outcome.
Correct. So
Is that a good statement?
yeah, that is a very good statement, because one bout of hypotension in a patient increases the mortality and morbidity by 50% or greater. It also increases the chances of getting that patient to a stable spot. Those chances increase also. So the blood pressure, everybody relies on their monitors. If you get a low blood pressure, you should automatically go to palpate the blood pressure or auscultate the blood pressure, because the monitors getting beat around and bumped around a lot of times. They may not be calibrated to what they need to be. So that's where trending that blood pressure and making sure you get a blood pressure that is accurate is vital for that patient.
So all
Also,
of these,
critical care people know coming in, hey, if I'm on that verge of the hypotensive crisis that I need, they're carrying blood and plasma now. We've already given the TXA if we needed to on scene before they got there, but they have the ability to put that blood back into it to help correct that.
so if you're coming to me on the helicopter and I've called you for a single vehicle accident, I got a critical patient, I've declared him red, a GCS of 8, let's say, or 9 or whatever, are you not going to want to know what that blood pressure is?
Of course, I want to know that blood pressure, because that's going to tell me if I'm bringing blood to the scene or if I'm going to leave it in the helicopter for later. If their blood pressure is already in the low 90s or high 80s, then yes, I'm giving them blood immediately on scene while we're getting other stuff done.
So my point being here is, it may sound elementary and stupid even, but my point here is that I've seen situations where we have not gotten blood pressure soon enough, and we've given a patient status, but we have no vitals on them. And that's where I mean by a lazy medic or a medic that's not really thinking ahead of, like, okay, I need to make an establishment of what this is, and if it goes up or goes down, at that point, that could mean everything, I guess, is really what my point is. Yes or no? Okay.
That goes back to color coding. When you first look at that patient, especially with some of our car wrecks, that's a red patient because of what's going on with them. That one where we had the motor knocked out of it a few months ago, before even climbing into the car and seeing the injuries of that lady as I was getting into it, I knew she was a red patient right off the bat because of the injuries that I could see from just an external overview of the patient. I knew she was going to be a red patient. And then getting in there and trying to get the blood pressures and all that to confirm our initial findings that we weren't just looking at her. So just looking at a patient, yeah, you can't color code them kind of quickly, and then update as you go and get that set of vital signs so that you have that benchmark and you can trend it on this patient, or is that patient getting worse, and we're going to have to back up and come up with another idea to try to stabilize this patient a little better.
Now, one of the things that, we ran through, we reviewed, but we're gonna kind of tie it all together here with a homework assignment that will reveal how seriously you take patient assessment. And what it's gonna consist of is a, learning this GCS score, and applying it to that, and this is how I would best recommend doing it. You could sit there and you can look at this and memorize this. That could work for you. If if it doesn't, if you don't know it already, then that might not be the most effective way. But what I'd recommend is a little game you can play with a partner, a 15-second game as you're clearing the scene, whatever the case. Hey, Chief Burnett, what's my GCS? And then I act, and he tries to, okay, hey Zach, open your eyes. Okay, so he knows I'm a 3. Do you know what day it is? Now he knows I'm a 2, so I'm at a 5. Hand me your arm. Hand me the arm 6. Okay, so we're at an 11. It took 15 seconds, and that can help to build, put it into action and help to cement that in your brain. Because it's very effective to play this little, war game of sorts, for lack of better comparison, to really cement this into your brain. Because I'll tell you what I've seen before, and I've started to see a little, lately as well, is a chief is more than happy to ask, what's the GCS? And, if you give them the number, let me relate this to me. So we had a car wreck. Guy drove off 53, hit a tree. GCS was 8. And, it was a 1, 1, and 6. Well, after the scene cleared, Chief Parker came up to me and he says, why was this GCS an 8? He knew the answer. And what he did not want to hear me say was, well, because he drove off the road and hit a tree. That's not the answer he's searching for. What he's searching for was the answer that you give him. So the answer I gave him was, well, he's an 8 because he's a 1, 1, 6. He wouldn't open his eyes. He wouldn't respond, but he followed commands. So, that's a weird one. But, we both kind of were like, I mean, that is weird, not opening your eyes, not answering questions, but you're handing me your arm, you're doing this, hey, sit, put your head up, this and that, so it was, they're asking these questions because they already know the answer. They're just kind of putting the spotlight on you to see if you know the answer. So it's, doing this, when I send this email with this GCS, I'll send this PowerPoint presentation, it's very easy to check to see if you've taken it seriously. Just takes a simple question from, anyone on scene. What's the GCS? 10. Well, why? Well, because it was, that's not the answer you want to give. You want to say because it's, is it 2, 5, and 3? That's the kind of answer you want to give. And you want to be that able to do it that efficiently at any time of the day. So it's, that's what I would recommend. I think that would be, if that's if you pop in a station to get fuel or see someone on scene, once you're leaving, whatever the case, spend 15 seconds and run by a little practice test and just, help each other learn, help each other grow as a team. That's a very effective way to learn it rather than just sitting there and memorizing.
Is that it, Zach?
That's it. Yes, sir.
All right, thank y'all. Let me say this, and I think we've talked about it. I don't remember which shifts we've talked about it. I think everybody knows that we're going to bring Trip on. We're going to elevate his responsibilities a little bit. He's willing and agreed to take over the medical officer for Harrison County Fire Rescue, as far as helping us to